Okay, let us begin our webinar. Right, good afternoon, everyone. Welcome to our weekly webinar organized by College of Physicians Malaysia. So, theme of this month is respiratory medicine, and we are very fortunate to have our chairperson with us today, Dr. Huan Nai Chen. A few words about Dr. Huan. He's a consultant respiratory, sleep, and internal medicine physician. He obtained his MRCP in 2016 and fellowship in respiratory medicine Malaysia in 2022. He subsequently obtained his fellowship in as a fellow of the American College of Physicians in 2024 and a fellow of the Asia Pacific Society of Respiratory in August 2024. He has published in numerous papers as well as reviewed journals worldwide. Without further ado, let us welcome Dr. Huan.
Thank you, Kelvin. Just to make sure that you can hear me.
Yes, we can hear you, Dr. Huan.
Okay, thanks. So good afternoon, everyone. And welcome to the webinar series organized by the College of Physicians Malaysia. I'll be the chair for today's session. My job is simple today, is to introduce our speaker today. Basically, for over the next 4 weeks, we will be diving into all things respiratory, and I'm truly honored to kick off the series today. The title for today's talk is on lung cancer, and the full topic is on lung cancer frontline, getting it right. I think we know that lung cancer is one of the most discussed and debated topic in the medical field right now. And I think it involves multiple teams, from respiratory all the way to cardiothoracic surgery, oncology, primary care, pathology, and so many more teams involved. And we are incredibly lucky today to have Dr. Tan Sin Ni joining us. She's a respiratory and internal med physician from Hospital Tengku Ampuan Afzan, or HTAA in Kuantan. And she's certainly someone with a deep passion for lung cancer, and all the way from diagnostics to therapeutics. A bit on our speaker today, Dr. Sin Ni graduated from UPM, or University Putra Malaysia, where she also later completed a Master of Science. She's a holder of MRCP and more recently was awarded with the FRCP from the UK. She's active and she's actively involved in various lung cancer, interstitial lung disease and airway diseases research, and is running multiple clinical trials across her hospital. So without wasting much time, let's take a deep breath, because I think you want to stay wide awake for this one. And please join me in welcoming our brilliant, insightful, and always inspiring Dr. Tan Sin Ni. The stage is yours, and you are ready to go.
Thank you, Dr. Huan, for your kind words. So thank you for College of Physicians Malaysia for the invitation. So I would like to share my screen now. Welcome everyone to join this webinar. So I'd like to share a bit of sharing of lung cancer frontline, getting it right. So in Kuantan itself, respiratory physician is the one that treating lung cancer, whereby in other state there are oncologists who are dealing with lung cancer. So it's a rare occasion for a respiratory physician to treat, but there is a few centers that actually treating lung cancer. This is outline of my talk today about incidence and mortality of lung cancer, the type of lung cancer, overview of lung cancer treatment, the lung cancer risk factor and screening, and a few case scenario and take-home message. So this is a global cancer statistic in 2022. Lung cancer is the most frequently diagnosed cancer in 2022, which is almost 1 in 8 cancer diagnosed to be a lung cancer worldwide. But not only that, the leading cause of lung cancer is the top of the list of many other cancer compared to other cancer. So you can see that the incidence is about 12.4% and the lung mortality rate is 18.7%. What are the idea of 18.7% is approximate 1 in 5 cancer deaths are attributed by lung cancer. So this is how high the mortality is in lung cancer. So let's zoom into Malaysia's statistic, the 10 most common cancer in Malaysia. So every 5 years, we will have a summary of Malaysian National Cancer Registry. So you can see from 2012 to 2016 is one 5 years data, and then the latest one was 2017 to 2021. You can see that the most common cancer in Malaysia is breast instead of lung, trachea or bronchus, which is located at the third most common in Malaysia. after the breast, followed by colorectal CA, and then lung CA, lymphoma, and nasopharyngeal or liver cancer in Malaysia. So why are we so different from the global data? I think that because in Malaysia there is very good screening programs in breast and colorectal. So mammogram is well known to screen for breast CA that you can pick up early stage, and also same go to colorectal, that fecal occult blood. And we have other good program like pap smear for cervical CA and also PSA for prostate. However, for lung, we do not really have a very effective and good screening tool to detect early lung cancer. So this is a summary of Malaysian national cancer. As I mentioned before, you can see that you focus on this lifetime risk. You can see that the latest report shows that it is more commonly seen nowadays compared to 5 years ago. So I would like to draw your attention for the staging. You can see that the number of female lung cancer diagnosis was increased about 300 incident after 5 years, but for male it's remained the same, about 4,600 for total of 5 years. What I would like to draw your attention is looking at the stage 1 and stage 2 disease, which is called the early stage of lung cancer, whereby curative is more higher chance to get curative treatment is about barely 5%. So this is what we are very worrying, that most of the lung cancer is present at late stage. The late can be a locally advanced or metastatic disease. It's about 95% of them are actually picked up at the very late stage. So what are the type of lung cancer? We are looking at majority of them are non-small cell lung cancer, which is 85% of the cases. Looking at this diagram, you can see for the non-small cell lung cancer, it's included adenocarcinoma, squamous cell carcinoma, and also large cell carcinoma, whereby another 15% is small cell carcinoma, which is very different in terms of management and treatment. So we look into the talking about lung cancer without talking about the TNM staging. So you can see this is the 9th edition of TNM classification for lung CA, which is very new since last year. So the T is mean a primary tumor. It's the size of the tumor and also the adjacent, whether the contact to the surrounding organs that will classify the tumor into a T staging. You can see from 1 to 3 cm, it's considered as T1. T2 is about 3 to 5 centimeter, or it touches the pleura, the visceral pleura. Okay, for T3 is 5 to 7 cm, but there is local invasion, for example, like a parietal pleura. And if there are two nodule that within the same lobe, like right upper lobe, there is two nodule, it's still, regardless the size, maybe there are just 1 cm, but two nodule together, it will still may classify into the T3 classification, and T4 is more than 7 cm, or there is mediastinal invasion. So next, we'd like to go to the nodal classification. You have N0, N0, there is N1, N2, and N3. What is new in 9 classification is this N2. They sub-classify into N2A, which is a single station of the lymph nodes, which I will show in the next slide. And N2B is more than one, maybe 2 or 3 station of the lymph node which is involved. So what is important here, they do realize that when you have only single station involvement of the lymph node, they tend to carry a better prognosis, and you will subject the patient more to curative treatment rather than palliative intent. So for the M1, which is the metastatic, distant metastasis, so the new thing is here, M1C1 or M1C2. In M1A, which is confined to the thoracic metastasis, like contralateral lung nodule, pericardial involvement, or a pleural effusion, or there is contralateral lung nodule, which means left there is a huge tumor, but left side there is another lung cancer tumor that it classified into M1A, which is giving you the stage of 4A. So a single extrathoracic lesion is where, let's say there is a lung lesion together with a brain lesion, single lesion. Then you consider it as a M1B, which is still 4A. But if you have multiple lesion, for example, a brain with 2-3 lesion, then we classify it as M1C1 in one organ. If you have brains and liver with multiple lesion, we call it as a M1C1, a C2, which by both give you a staging of 4B. So this is a nodal classification. It's a bit complex, but just brief you through. There is a lung mass over the left lung. So N1 is the hilar nodule. So this is station 10 and 11. If there is involvement in the lymph nodes over this area, it will be N1, give you a better prognosis compared to N2 and N3. So N2 is a mediastinal lymph nodes. We have station 2, 4, 5, 6, 7, 8, 9. So those are the lymph nodes that we need to sample if possible. Mostly are 2, 4, and 7. If it's positive, then they give you an N2 disease, ipsilateral mediastinal lymph nodes, where the tumor site is. So if you have contralateral lymph nodes, that it will classify into N3, the contralateral hilar or mediastinal lymph nodes. For station 1 is supraclavicular lymph node. Regardless where the tumor is, when you have supraclavicular lymph node, it fall into N3 disease. All right. So what are the difference between the 9 classification and 8 classification? So you can see that they divide into the N2A and N2B, and also N1 disease. When the tumor is about 1 to 3 cm with N1 disease, they bring forward the classification as a 2A disease, whereby it carry a better prognosis. And for N2 disease, it used to be 3A without subdivide into the classification of the single station nodule or multi-station. So single station nodule tend to be better prognosis in this case. And last but not least, the M1C1 multiple lesion, it carry as a 4B. But M1C1 has better prognosis compared to M1C2. So other than TNM staging, for small cell lung cancer, there is another staging is a veteran administration. This is mainly for only small cell that they divide into a limited stage or extensive stage. So for limited stage, there is this stage 1 to 3. Usually they can safely treated by a single radiation field. So it's presented in 1/3 of the cases, while extensive is any M1A or B or C, meaning it's already beyond a single tolerable radiation plan. We call it as an extensive disease. So why the staging? We talk so much about staging because that tell us that the 5 years lung cancer survival rate by the stage of during the diagnosis. We can see that if there is M1A, which is the size of the tumor is 1 to 3 centimeter without any lymph nodes, it carry 52% of the 5-year survival, meaning still about 10% of the patient actually will progress and die within 5 years. But when you have M1B, when there is lymph nodes involvement, your 5-year survival is tremendously dropped to 68% only. So meaning that 30% of the patient will still die despite they are at stage 1 lung cancer. Last but for this staging, you can see even stage 2, which is quite an early stage of CA, also they carry quite a poor survival for coming 5 years. You can see the dropping. The worst will be stage 4 is less than 10% of the patient actually survive more than 5 years. So lung cancer has the largest cancer death in worldwide. So looking at this data is actually from the developed country like Europe, US, and Japan. You can see what did I mention earlier is in Malaysia is 95% actually diagnosed at the advanced stage, not advanced stage, I would say locally advanced or advanced stage there. But in a developed country is about 65% only. Compared to ours is 95%, just now I have mentioned. So in developed country, they tend to pick up a bit more. Probably they have a good screening tools in picking up early lung cancer to improve the survival. So we go into a lung cancer treatment. This is very lengthy, but I'm going to go through it briefly. for this session because it's quite short. So for limited stage, as I mentioned earlier, the treatment is aimed for curative. We want to cure the patient from the lung cancer. So in very early stage, it's stage 1 to 2, meaning that the size of the tumor is about 1 to 5 centimeter without lymph nodes involvement. Then you can aim for surgical resection. You want to resect the patient, resect the lung cancer, and then followed by adjuvant chemotherapy. If you have R node resection, meaning there is no clear margin, there is no remaining lung cancer, or the margin is not clear, or lymph nodes involvement, you will go into adjuvant chemo. But if there is no clear margin of resection, you will offer a concurrent chemoradiotherapy for this patient. So for those who have a bit more advanced stage, a locally advanced stage, you will consider a concurrent chemoradiotherapy or sequential, meaning you give chemo first followed by a radiotherapy. If there is no progress or there is no progression of the disease, you will consider a prophylaxis cranial irradiation for this patient, because when small cell recur, they tend to go to brain. So prophylaxis cranial irradiation is it's recommended in this group of patient. So what about extensive state of small cell lung cancer? So we are no longer aiming for curative intent. This is for palliative intent. So for those who have very good ECOGs, no contraindication for immunotherapy, meaning they don't have contraindication or they can afford, because immunotherapy is not given, I mean, that is not in the blue book yet. So you have to self-purchase if you wish to get a chemo with immunotherapy for small cell lung cancer. So if you have contraindication, then you would just go with a platinum doublet, which is a carbo-etoposide, the most common regime. Then we will give to the patient. If patient responded very well and the tumor shrunk into a radiation field, then you can consider a consolidation of radiotherapy and then followed by a prophylaxis cranial irradiation. If the patient have very poor ECOGs, it's usually best supportive care, and also sometimes we will try on, after we discuss with patient, we may try on single agent chemotherapy if the family willing to take the risk, but it's still case to case basis. So after the small cell lung cancer, we will talk about non-small cell lung cancer, which is there is a lot of advancement in this non-small cell lung cancer. So for non-metastatic, meaning from stage 1 to stage 3, early stage, if you are able to resect the tumor, you may consider a neoadjuvant or perioperative. This is before the resection, you give the treatment first and then followed by the treatment after that. If patient doesn't need the neoadjuvant therapy, then you will follow by after resection, you will follow by adjuvant therapy. So for those stage 3, which is unresectable, especially 3B to 3C patient, you will do a consolidation after the CCRT, or we call it as concurrent chemo radiation, and then followed by the treatment if patient profile is suitable for the consolidation treatment. For metastatic non-small cell, just now is same, is curative intent. This is a palliative intent. So we no longer at the stage of we just chemotherapy with chemotherapy only. We are now moving forward to phenotype the cancer, and we have to determine the mutation stage of the tumor. Especially we are sending EGFR, can be PCR or NGS. So there is a lot more mutation nowadays that can be targetable. For example, it's MET mutation, ALK fusion, ROS1, BRAF V600E, or RET fusion. There is many more targetable mutation that the treatment is available now. So if you have the targetable mutation, you will start your TKI, tyrosine kinase inhibitor. Once they progress, then you will reprofile the patient again, and then it either change to another TKI if that is targetable mutation, or you change to chemo or with or without immunotherapy. So if you have no targetable mutation, you will go to standard chemotherapy with immunotherapy as standard of care. But again, in Malaysia, immunotherapy is not easily available and you have to pay it out of pocket. So with that, that's the overview of the treatment of non-small cell, stage 4 non-small cell lung cancer. So the first chemo actually invented in 1940s. So it's been a very long time only we discover a targeted therapy. After almost 60 years, we get our first gefitinib in IPAS study in 2000, about 1998 or about 2000. So when we first discovered targeted therapy is a change or shift of the lung cancer treatment. So you can see that in 2010 and 2020, there is a lot of targeted therapy and also immunotherapy actually invented and start using on patient. However, with the 30 years, this is the 1975 to 2021, the improvement of the 5-year survival rate for lung cancer is still remain low, and despite we have spent so much of money, and the survival rate is still remain the lowest among all the cancer. So what we need to do, we all know that prevention is better than cure, but what can we do? So the first thing is fighting against the tobacco or smoking. So smoking is the leading factor for lung cancer and is responsible for 80% of lung cancer death. Looking at this lung, smoking is one. Passive smoking is one of the risk factor. We have environmental exposure like asbestos or some metal or organic bacteria, and radiation is another one. With another one is radon gas. So for genetic in lung cancer, we still not very clear what are the genetic mutation that exist in lung cancer, but we know that genetic more towards a non-smoker patient. And not to forget that post-TB fibrosis or idiopathic pulmonary fibrosis or COPD scarring are the independent risk factor of lung cancer. Usually they are associated with smoking also. So with that, if we can't prevent, then we try to do early detection to improve the lung cancer survival. If we can detect early, hopefully we shift the survival curve to to a higher chances of and longer survival rate. So there is a lot of study that carry out for lung cancer screening. So the first one is this national lung screening trial carried out by the US team, that they do a low dose CT to screen for high risk patient. So high risk patient considered as 55 years old to 75 years old. They smoke 30 pack years, or they just quit smoking less than 15 years. So those are the three criteria that they screen on the patient for lung cancer screening. Another study is Nelson study. This is done by the Dutch and also Belgian group. And also not to forget the UK group, also they are doing a large cohort study in screening lung cancer. So what they do, they start on a low dose CT screening and then they follow up the patient. In 3 major study, they do find that by using a low dose CT to screen on a high risk patient, it does reduce lung cancer mortality by almost 20%. However, can that be applied in Asia country or Malaysia? So we do have this evaluation of pulmonary nodule in the consensus in Asia. So in Malaysia or Asian country is a bit different demographic and also environmental issue. So in Asia, we have a lot of indoor and outdoor air pollution, for example, like India or China. And we have very high incidence of adenocarcinoma in female non-smoker, which is very different from Caucasian population. Other than that, in Asia, we have high prevalence of granulomatous disease and also in other infection causes that cause you to have granuloma or some nodule, which is post-infection scarring, that what is the remaining sequelae of the infection. So it tend to be false positive, and patient will subject to intervention for all this nodule investigation. So if we need to be, whatever that developed in Caucasian country may not be applicable to Asian population. So I would like to draw your attention in this study. Uh, Before this is all high risk patient. So what about female, which is non-smoker? So in this Lancet, this paper published in Lancet, this is a Taiwanese study. It's a population study also. Taiwan lung cancer screening in never smoker trial. I think this is more closest to us because we do have increasing number of female non-smoker who diagnosed to have lung cancer. So I'd like to take some times on this slide. So they are looking for the individual with negative chest x-ray, age 55 to 75, never smoker or smoked less than 10 pack years, or those who have stopped smoking for more than 15 years. With one of the following risk factor, they must have either is family history of lung cancer, passive smoke exposure, TB or COPD, cooking index of 110 or even higher, or cooking without using ventilation. So those eligible participants will be undergo a baseline low dose CT screening and then follow up by every 2 years. So let's look into the result. That look at the 12,000 participant enrolled is nearly 3/4 of the patient are actually female, and half of them do have family history of lung cancer. So when they screened, they picked up 2.6% of patients who diagnosed lung cancer, which is quite high compared to the previous study that I have shown you. It's about 1.8 to 2.2% of cancer detection rate. So in this group of patients, they actually detect even higher lung cancer detection. So what are the contributing factor is, after they have do the analysis, females sex, a family history of lung cancer, and patient older than 60 years old are the association with the increased risk of lung cancer in this group of non-smoker patient. Other than that, they do not find any correlationship to the passive smoker or exposure to cooking or cooking without ventilation. Even the previous history of chronic lung disease are not associated with lung cancer in this trial. Okay, so what are the family history? So those with first degree relative who have lung cancer have the higher chances of lung CA. So for low dose CT is quite sensitive, about 92%. It's very specific to 85% to detect lung cancer diagnosis. So what happened in Malaysia? Do we ever try to do a lung cancer screening? Yeah, we do have one pilot study for early lung cancer screening. It's called PEARLS, but I'm not aware of. I just find that this article is very limited information on this trial. So it was terminated earlier because of poor recruitment, likely due to low awareness. Patient refused to screen. They are fear of cancer diagnosis. It is what happened. We so close to us that we know that patient a lot of time they are in denial. They have a lot of fear. That so we try to overcome it. So what happened now is the health minister now they wanted to do a AI power of lung health screening for high accuracy effectiveness in early detection. This is to aim for mainly asthma, COPD, and also lung cancer. They want to use the AI chest X-ray to try to pick up lung disease earlier. So we call it as a National Lung Health Initiation, which is from this year onwards until 2030. This is to strengthen the prevention, screening, and treatment activity for lung diseases. So what can we do now? I mean, as a frontliner, as MO or physician that you are seeing patient in various primary care or hospital level. So what we can do is, so we try to screen patient or try to investigate further and put in your mind that when patient presented with blood when you cough, hemoptysis, a recurring respiratory infection, recurrent infection, and during cough, pain over shoulder, back, or chest, shortness of breath, trouble breathing, hoarseness or wheezing, and exhaustion or fatigue. So breath. So that's the mnemonic that you can remember, that you need to screen for lung CA in this group of patients who presented with the symptom. Other than that, swelling over the neck, the face, like SVCO, difficulty in swallowing, and weight loss. So what happen if they have no symptom but you can screen them? So take up the chances to screen the patient that who are at risk. So they are at 50 to 80 years old, they have smoked about 20 pack years to 30 pack years, or they just recently quit smoking less than 15 years. So we can screen them for lung cancer. Not to forget, try to ask family history of lung CA, that you might pick up some of the patient. So I'd like to go into case discussion. So I have this early stage lung cancer cases. I have this 46 years old gentleman, lecturer, active vapor, have history smoking about 15 pack years. There is an incidental finding when he planned to do his further study. So he do a body checkup and then they picked up a opacity over the right upper lobe. Sorry. So this is a CT that you can see that there is like a consolidative light mass over the right upper lobe, and it's actually buckling to the parietal pleura or visceral pleura. We are still unsure. Okay, so there is a lymph nodes, hilar lymph node seen over the right side ipsilateral. So it could be a N1 disease. So we discuss with the patient, because my center, it's quite a limitation in terms of diagnose distal lung mass, which I couldn't visualize directly. So we actually offer either CT guided biopsy or trial of transbronchial lung biopsy. But patient decided for transbronchial lung biopsy, and we managed to get the diagnosis of lung adenocarcinoma. So this is a young gentleman. We have proceeded with PET-CT because we think this is an early stage. So we have done a PET-CT, given the staging of T2A, N1, N0. The mass is about 3.5 centimeter. It's extending to the adjacent lung pleura and also pick up the hilar lymph nodes. Ideally, he should undergo a mediastinal nodal staging, but our machine just out of service since last year, so we couldn't perform a systematic mediastinal staging. So MRI brain is clear, spiral is normal, ECOG is good. So it fall into this adjacent there is a contact to the maybe a visceral pleura, and also it's 3.5 centimeter. So it's N1 disease. He fall into stage 2B disease. If let's say the operation is performed and there is invasion to the parietal pleura, so it might go into T3 with N1, which is a 3A. So we are still not sure pathological staging. So in this case, looking back to the survival rate, so patient fall into stage 2, and he has 50 to 40 to 50% that he might not survive beyond 5 years. So it's still quite, despite it's early stage, but it's still the recurrent rate is high and the mortality is also high. So looking at this case, so he will fall into after the surgery, and then we get the staging. Then patient will receive adjuvant treatment, meaning after resection, then he will get a chemotherapy for 4 cycles followed by adjuvant therapy. So because we know that the recurrent rate is high and the 5-year survival rate is low even in stage 2. So we actually discussed with patient in that offering a standard of care, which is adjuvant chemo followed by pembro, but added on another anti-cancer. It's like an anti-cancer vaccine for now. We call it as an individualized neoantigen therapy, which is Interpath 002. So the patient will randomize into either an anti-cancer vaccine or placebo, together receiving a pembrolizumab after 4 cycle of chemotherapy. So for your information, immunotherapy is very expensive. They cost about 200,000 per year. So by enrolling patient into clinical trial, they might, for those who can't afford the immunotherapy treatment, may get a free immunotherapy in this setting. So we are still in the midst of discussing with the patient, but he seemed very interested in this trial. Yeah. So let's move on to advanced lung cancer cases. So I have four cases. Case number one is a 63 years old man smoker, and let's try to for those audience, you all can vote which case are not lung cancer. So probably you all can comment in the chat box. So I have case number one, 63 years old man, smoker. So we can see that there is right upper zone opacity, rounded, very round, with reticulation, and mediastinum is a bit prominent, and there is multiple reticulation seen in this X-ray. So case number two is a 58 years old man, non-smoker. I can see that there is very obvious left lower zone consolidation, I would say. Difficult to tell whether it's mass or not, but they look like consolidation. Okay. For case number three is 65 years old lady, non-smoker. Obviously, you can see a right upper lobe, homogeneous opacity over the right upper zone, I would say. So case number four is a 27 years old lady, non-smoker. So looking at it, there is right upper zone, homogeneous opacity with, I think there is lung collapse somewhere because the diaphragm is markedly elevated, and there is a lot of ground glass over bilateral hilar region. So yeah, I would like to see. You all can comment in the chat box. So let's see. Case number one, Mr. R, is a 63 years old gentleman. He's a Orang Asli, a very heavy smoker. So he do presented with cough, visited KK back in 2021 February, and he got loss of weight. So he's a heavy smoker, working odd job, no hemop, no fever, and then there is the other systemic examination is unremarkable. So close contact to the brother-in-law who have PTB back in 2018. There is no other family have TB or lung disorder, no lung cancer history, and on examination, it's only right upper lobe is reduced air entry. So the investigation done by the KK, sputum AB negative, and CNS is pending that time, ESR mildly raised, and the rest of the blood is normal. So there's quite standard KK send chest X-ray for reporting. So the reporting came back to be well-defined opacity right upper lobe, upper zone, sorry. Several opacity over the left upper zone may represent granuloma with right hilar dense opacity here. Okay. So question, will you treat as smear negative PTB because there is granuloma, there is upper lobe and opacity, and the report come back to be granuloma and history of contact despite AFB is negative. So yes, the answer is yes. So they treated as a smear negative PTB and they started on accurate. So 2 weeks later, they plan to repeat another AFB. So the second visit was March 2021. Patient is compliant, weight static, AFB still remain negative. So the X-ray commented is right upper zone opacity is improving. They continue the anti-TB because patient have no active complaint. So the third visit is in April. After the 6th week, he have completed the intensive phase, weight static, compliance, no active complaint. So patient actually switch into maintenance phase for this for the smear negative TB. So this is a January chest X-ray. The March chest X-ray, still the right upper zone opacity, and this is the April chest X-ray. When you see discrete separately, you might not picked up the mass is actually slowly growing in size. So you can see the January, the March, the April. If you bring up and compare, I'm sure you will pick up the mass is actually growing in size rather than the comment just right upper zone opacity. So it is make a difference when you're comparing the chest X-ray. All right. So in June, so when you see back in 2 months' time, so compliance, finally there are people actually picking up the right upper zone mass is actually increasing in size, but they still continue the TB because probably patients are asymptomatic. And the MTB CNS have no growth. So eventually in September, when he completed everything and found it's worsening right upper zone consolidation, so they discussed with FMS, they off the NTTB and then refer chest team. So this is the final X-ray when the patient presented to us for further investigation. So this is a CT scan that you can see a huge mass over the right upper zone, upper lobe. So that is we biopsy the mass. It turned out to be a squamous cell carcinoma. So this is a second case. Mr. S, 58 years old, visited private hospital in November. So same cough and weight loss for November until he came to us in April. So after 6 months of symptom, is a non-smoker, chronic cough, no loss of weight, no loss of appetite. Other than cough, he do not complain of other things. So went to private hospital, actually done a CT scan, commented of left lower lobe consolidation. He was given a prolonged course of antibiotic. Symptoms subside for a while and then it recurred. So actually came to us, and then in April, after we see this, we decided to go into biopsy. So we did a bronchoscopy and also transbronchial lung biopsy. The At that time, I think the HPE came out to be there is acute inflammation that we can't get a definitive diagnosis. TB workout is all negative, gene expert negative, and then MTB CNS was pending at that time. So we actually arranged a city guided biopsy for this gentleman. However, he was the city guided was delayed for twice because both also the BP shoot up to very high when the time we push down to CT suit. So they have to cancel the case. So June, the second time when he was uh, uh, he was denied from doing the CT guided biopsy, we discussed with the consultant, senior consultant, regarding what is his impression, because AFB turned out to be negative, gene expert negative, even culture was negative. So when we discuss through the case, we say why not we bronch again, and then we will actually start as a smear negative PTB, start treatment. So we went in and bronch again. Gene expert still negative, so we started anti-TB at that time. But at the same time, we still getting a city guided date for this gentleman. So it turned out after anti-TB for a month, you can see that slight improvement over the right lower zone opacity. So, but we keep the CT guided biopsy. Eventually, it turned out to be a adenocarcinoma after the CT guided biopsy. So we send patient for. We are thinking of could it be dual pathology? So we send patient for PET CT, just to give us a clearer guidance what are we dealing with. But however, after a month, we can see that there is nodular opacity seen, and we conclude that this is a lung cancer instead of an PTB. So we off the anti-TB and we initiated the lung cancer treatment in this gentleman. So this is a CT scan which can be very misleading, that you see more towards ground glass and also consolidation rather than a tumor like the first case. So this is quite a very challenging case for us. So point of learning for these two cases, we think this is you think twice before you initiate smear negative TB treatment, close monitor, always compare the x-ray, and also you have to act fast when patient is not responding to anti-TB. So my last case, this is case number 4, Miss H, 27 years old. It was referred from KK in March 2025. So patient have no cough, presented with prolonged cough, no other symptom, very cheerful lady, and then investigated in KK for TB, is all negative. Looking at it, I was like, could it be TB? Yes, like a right upper lobe or granuloma or lung collapse due to endobronchial TB with ground glass changes. So this is a CT done. We can see that there is right upper lobe mass, and also there is ground glass opacity. So this case I was discussing with my senior consultant. I said, I know this is mass, but I can't explain why there's so much of ground glass in this CT scan. Could it be dual pathology again? Could it be COVID? Could it be any viral infection? So from the X-ray from January, we decided in March when I see her, we decided to repeat the X-ray, and the ground glass is actually persist. So we actually did a bronchoscopy on her. This is what the right apical mucosa seen. With one look, it looked exactly the same mucosa. It is like external compression from outside. So I call in my senior consultant and then I ask him, I don't think when I bite here, I can get the diagnosis. So we did several procedure in her. So we do a TBNA, which is you pierce through the mass over this external compression. And we did a transbronchial lung biopsy through this area. And also we do endobronchial biopsy, this part, endobronchial, we bite through the what we can see. And also this the consultant actually asked me, you don't want to bite the middle lobe, the ground glass opacity? I said, okay, I will bite it. Okay, so we have done several procedure in this case. So we can see that transbronchial lung biopsy, we picked up adenocarcinoma, but very minimal cell. They actually can't really they can't really conclude. But after they see the transbronchial lung biopsy over the middle lobe, this area, so they are quite confirmed that this is adenocarcinoma. And what is right is endobronchial biopsy, there is no malignant cell seen. So meaning that there is actually external compressed to the airway. So we did a transbronchial needle aspiration on the mass. Also, it turned out to be adenocarcinoma. So in this case, she was so young that I couldn't believe that the diagnosis of adenocarcinoma in such a 27 years old lady. There is no family history. She's 27, she's non-smoker. So it is very sad to diagnose and to break the bad news to her. But we tried to screen her for clinical trial. So we sent NGS for her, we sent PDL1 level for her. So she came back to be a KRAS G12C positive. So we do have a treatment. We do have a clinical trial for her, which is quite a lucky in unlucky situation that this trial is sotorasib. Is an oral thyroxine kinase inhibitor like TKI, comparing to pembrolizumab with chemo as a first-line treatment. So sotorasib has been approved for second-line KRAS G12C patient, but it's not the first line. So she is the very first one to try on this sotorasib. Is that better than chemo plus immunotherapy in this trial named CodeBreak 202. So this is the last. I have two more slides. Okay, this is a lobar pneumonia. Actually, the third case is actually lobar pneumonia. Looking at it, they done a CT. It's looked like consolidation and also a mass-like consolidation. So we decided to biopsy, and it turned out to be acute inflammation. So we actually wanted to go in for second biopsy, but when we repeat the X-ray after a good antibiotic, it's actually resolving. So chest X-ray can be very deceiving. So this is the diagnosis and assessment for the frontliner. So you will have a medical history, physical examination, X-ray, and then when you have suspect the possibility of lung cancer, you refer to us. So the chest physician will walk through the patient's subsequent investigation and diagnosis and treatment together with the oncologist and cardiothoracic surgeon. So I always tell the patient, biopsy is just the first step of the lung cancer diagnosis, and there is much more journey to work with the patient subsequently. Yeah. So with that, the take-home message is lung cancer is the most diagnosed the cancer worldwide. Most patients diagnosed at late stage. So despite the advancement of treatment, the lung cancer mortality still remain high. What we need to do is control the risk factor and early detection. We have to act fast, refer early. So I thank you for your attention. Just two more slides. I would like to promote our Malaysia Thoracic Society Annual Congress 2025, going to happen in August 14 to 17 in KLCC. Last but not least, we do have those who are interested in intervention. We have our Malaysian Association for Bronchology and Intervention Pulmonology. We call it MABIP. It will be held in Courtyard by Marriott in Malacca in September 12 to 14. We welcome all of you to join us. Yeah, with that, I thank you.
Thank you very much, Sydney. I think it's a very insightful presentation. I think by now, I think the audience should be quite clear that lung cancer indeed has many phases. It happens in very young patients with no apparent risk factors. And if you leave it there, it typically grows very rapidly. So early detection is really the key. What I'll do is I'll go through some questions. There are some questions being posted. The first question is posted by Mr. or Mrs. or Miss Anonymous Attendee. Anyway, it says, recently in news by KKM that a trial use of AI in detecting lung disease will be applied in selected premises. So do you have any idea on how is this done and whether it screens through the traditional risk factors?
Yeah, so thank you for the question. You're very up to date. Yeah, I got the message from my head of service that they're going to announce. I don't know, can I talk about it? But it looked like it's going to happen soon. They're going to start on 7 KK Klinik Kesihatan to do this health screening with AI chest X-ray. So I think the 7 area will be one in Selangor, two in Selangor, one in Kuantan, which will be the person in charge. And so in Penang, there is one, and then Kedah, Kelantan, and Sabah. So these 7 klinik kesihatan will be the pioneer to have this lung health screening by using AI. And for the risk factor, I think there is a chart for you to follow. If they have a few, the one that the breath, the symptom, if you have picked up a few raspy symptom, then you should screen them by using the AI X-ray and also spirometry, so that we can pick up the case early, and then we do an early investigation to pick up lung disease. Not only lung cancer, we are focusing, the lung health is actually focusing on asthma, COPD, and also for now is lung cancer. But we hopefully to extend further to interstitial lung disease and other lung diseases. But for now, they are focusing on 3 diseases. Yeah.
Allow me to just chip in a little bit. Like what Sydney said, it is a pilot study. I think it started off at IKN, if I'm not wrong. And I think this is part of the SAPU program, which stands for Saringan Awal Paru-Paru. So I think because they see some positive results, and now like what Sydney said, they are going to expand it a bit further. So let's move on to the next question. Hello from UK, nice talk. In preparation of my return to Malaysia, question, is it a common practice in Malaysia to start treatment for TB if smear negative or negative gene expert? What do you think?
Yeah, thank you for the question. Yeah, I guess in some center they have quite a low threshold to start, because we do not want the TB to be spread despite they are smear negative or gene expert negative. If That's why the TB divide into a clinical diagnosis and also bacteriological confirmed. So it is still back to the treating physician, who think that if this is very suggestive of TB, you may start on anti-TB treatment in Malaysia. But some of us, I think we are more towards a clinician that actually wanting to do a bacteriological confirm prior to starting anti-TB. So there is two school of thought, but I think it's not wrong to start empirical anti-TB, but you need to be close monitor so that you don't miss, because this is a smear negative TB and they might have side effect of the anti-TB, or the diagnosis may be wrong. So they need to be very close monitor. That's why in Malaysia, the guideline, if you are smear negative TB, you need to refer to the chest physician for further investigation or monitoring in this case. Yeah.
Yep, basic. Next question. May I know whether there is a role of periodic chest X-ray to screen for lung cancer?
Oh, okay. So in this case, I couldn't answer because I think in worldwide there are they fail to prove that the periodic chest X-ray actually help to reduce the lung cancer mortality, because most of them are using low dose CT. So I don't think at this point of time the X-ray is actually is a good tool to do the screening. But however, in high risk patient, I think we should do at least a baseline chest X-ray, and also when they have symptom, or a baseline chest X-ray. Yep.
Yep. I think you have more and more questions popping in, but I think in the interest of time, what I'll do is I'll just probably choose two more according to the order. There's one question on how do you choose patient for neoadjuvant or adjuvant chemo or TKI? For example, at early stages, at early stages, do you continue TKI after surgery? What are your thoughts on that?
Okay, this is a very huge topic. Okay, the question is actually gone. Sorry, let me
Okay,
just
I'll
have.
bring it up again. So,
It's okay.
yeah, do you have it?
Wait, let me just have a quick look. Sorry,
How
it's
do you choose your patient for neoadjuvant and adjuvant chemo? I think it's a very big topic to answer, to be honest.
yeah, it's very big topic. It's still bound to the MDT meeting that let's say clear cut a stage 1 to 2, which is the surgeon are very confident to remove the tumor clearly. They can do a R node resection, meaning they can do a clear margin and lymph nodes clearance. You usually proceed with surgery followed by adjuvant chemo therapy or TKI. So chemo or TKI as an adjuvant is depending on the EGFR status. Let's say after surgery, you cut the tumor and then you send for a molecular genetic. He has EGFR positive, then you follow by osimertinib. So that's the way how we choose. If there is no EGFR or ALK, for now it's only two EGFR or ALK. If they have no mutation, you will follow by adjuvant chemo plus immuno is the ideal standard of care. But if you have no money for immuno, you will just go with chemo. For
Yep.
neoadjuvant, mainly for stage 2 to 3, that they found the tumor are bulky, they find difficult to get a R node resection, so they might consider a neoadjuvant or a neoadjuvant treatment or perioperative treatment. Then when they downsize the tumor, then they go for surgery, followed by adjuvant treatment. So that's how we choose the patient and usually go through a MDT meeting. So for stage 1 to 2 cancer, we continue TKI long term for surgery. So post surgery, if you usually stage 1B and above, which is your Odora trial, you will you will start the patient on osimertinib. The Odora is 3 year. They will start after the surgery. If there is EGFR positive, they will start on osimertinib for 3 years. So far, it's far superior than a patient who have best. Comparing to placebo. But 3 years down the line, and when we follow up the patient into 4 year, 5 years, they look like the curve is actually merging. So meaning that the osimertinib are actually not curing the tumor but delaying the progression. So now there is this new study called Target. So they are extending the osimertinib to 5 years. So they are hoping actually to find a solution for this question, long-term TKI. How long and when are we stopping, and can the TKI cure the tumor? So we are still waiting for the result from the coming study. Yep.
Yep. I think we are running out of time, so I'll leave you and spare you from further questions. I would like to say a big thank you to all the participants for tuning in and for posting your questions. I do apologize if some of them cannot be answered. You are free to send a text to Dr. Tan Sin Nei. I suppose she'll be more than happy to answer them. I'll pass the stage back to you, Kelvin. Thank you very much for joining today.
Thank you.
All right. Thank you, Dr. Juan, for chairing the session, and Dr. Tan for the wonderful talk. And thank you for joining our webinar today. We will see you next week. Goodbye.
Thank you. Bye bye.